Good morning. For today's video, I'm going to demonstrate to you the emergency management for shoulder dystocia. Number 1. Gather all items that you need for internal examination. First, I will gather all items needed for the procedure for easy accessibility. The rationale for doing this is for easy accessibility of the inspection of the external genitalia, vagina, and the cervix. Number 2. Identify the client, introduce yourself, and explain the procedure. Good morning, ma'am. I am Jomar Bisperas and I'm your nurse for today. I will do internal examination by inserting my glove finger to assess the progress of your labor. The rationale for doing this is to obtain client cooperation and work simultaneously. Number 3. Position the client in the examination table. There are 3 positions are employed for internal examination: the dorsal recumbent, Sims position, and knee chest position. Ma'am, you will be positioned on the examination table to assess the progress of your labor. Number 4. Drape the client. Expose only the gynecological area. The rationale for doing this is always respect the client modesty and provide privacy. Ma'am, I will put the drape on you for your privacy, and I will just expose the part that I only need to assess. Number 5. Wash hand and put examination gloves. The rationale for doing this is to protect the healthcare provider from getting gynecological diseases caused by highly infective organisms. I will do hand washing and put on examination gloves to assess the client's progress of labor. During emergency delivery, notify assistant or backup to enlist other appropriate healthcare providers, including those healthcare providers skilled in neonatal resuscitation. I will notify other healthcare providers to assist or back up me up during the emergency delivery and neonatal resuscitation. The rationale for doing this is when shoulder dystocia is suspected, the nurse can be prepared to assist, staying calm and calling for added assistance with healthcare providers. Next is perform the McRoberts maneuver by helping the client to move to a lithotomy position in bed, supine with the buttocks at the edge of the bed. Lower head if the bed is elevated, and then hyperflex the both legs. McRoberts maneuver is done by grasping the mother's posterior thigh and flexing them against her abdomen. I will instruct the mother to grasp her thigh and flex them against her abdomen, like that, assuming that he is holding his posterior thigh. The rationale for doing this is when performing the McRoberts maneuver, straighten the sacrum and decrease the angle of inclined symphysis pubis and dislodge the impacted shoulder. Next, perform the Mazzanti maneuver. Mazzanti maneuver is done by applying suprapubic pressure applied with the heel of the clasped hand from the posterior aspect to the anterior shoulder to dislodge it. This is done by another healthcare practitioner. Apply a steady pressure first, and if unsuccessful, apply a rocking pressure, but do not use a fundal pressure. Mazzanti maneuver is done by applying pressure on the suprapubic region is done to dislodge anterior shoulder and simultaneously instruct the client to bear down. While I apply suprapubic pressure downward with the palm or fist, 30 seconds of continuously pressure. The rationale for doing this is, in combination with the McRoberts maneuver, this will deliver the baby 91% of the cases. Fundal pressure is to be avoided to prevent the potential neurological complication. Next, vaginal approach. Perform the Rubens maneuver and reverse word screw maneuver. This is done by adduction of the anterior shoulder, applied pressure to the posterior aspect of the shoulder. Next, the shoulder is pushed towards the chest or applied pressure to the scapula of the anterior shoulder. Robin maneuver, reverse wood screw maneuver, is done with inserting my fingers behind the posterior aspect of the anterior shoulder and rotate the shoulder toward the fetal chest. Mom, I will insert my fingers behind the posterior aspect of the armpit of the fetus, then I will rotate the shoulder towards the fetal chest. The rationale for doing this maneuver attempt to position the shoulder to utilize the smallest possible diameter of the fetus to the largest diameter of the woman. Next, rotation of the posterior shoulder, wood screw maneuver. It is done by applying pressure to the anterior aspect of the posterior shoulder, and an attempt is made to rotate the posterior shoulder to the anterior position.
Wood screw maneuver is done by inserting two fingers on the anterior aspect of the posterior shoulder while pressure is applied to the anterior aspect of the posterior shoulder. An attempt is made to rotate the posterior shoulder to the anterior position.
The rationale for doing this is when you success, this maneuver allows easy to deliver that shoulder once it passed through the symphysis pubis. Next is manual removal of the posterior arm. The arm is usually flexed at the elbow. If it is not, pressure in the antecubital fossa can assist with flexion. The hand is grasped, swept across the chest, and delivered. Delivering the posterior arm is done by applying pressure intravaginally at the antecubital fossa, which causes fetal arm to flex, and I will grasp it and sweep across the chest and toward the opposite side of the fetal face. The rationale for doing this may lead to humeral fracture if it is not done properly. It does not cause permanent neurological damage. Next is episiotomy. This procedure is done by the obstetrician. Next, roll over to all four position. Gaskin maneuver. It is done by assisting the client to roll onto the hands and knees and applying downward traction to deliver posterior shoulder, and may be repeated if needed until the shoulder is delivered. Gasking maneuver is done by assisting the client to roll into hands and knees, and I will apply downward traction to deliver the posterior shoulder that can be repeated until the shoulder of the fetus is delivered. Cut. Rationale for doing this, gasking maneuver moving the woman to all fours appears to increase the effective pelvic dimension, allowing the fetal position to shift. This may disimpact the shoulder. This is believed to increase pelvic size and make use of the force of gravity. Next, call out the time of birth and gender of the baby. The rationale for doing this is to safeguard the mother and the baby against infection, and to facilitate the spontaneous breathing of the infant. I will call out the time of birth and gender of the newborn, and if the baby is crying, I will proceed with EINC. If the baby is not crying, I will cut the cord and resuscitate the infant. Next, after delivery, assess the baby's motor reflex. Check for a fractured clavicle or humerus. The rationale for doing this, a complete symmetric motor response usually indicates no brachial plexus injury, which is the most common serious resulting in injury. After the delivery, I will assess the baby's motor reflex and check for the fractured clavicle or humerus for possible injury. Next is assess for postpartum hemorrhage. The rationale for doing this is because this is the greatest risk of the mother for having a shoulder dystocia. The hemorrhage is usually related to the uterine atony or vaginal or cervical laceration. After delivery of the placenta, I will check for its cotyledons. If it is complete, I will assess for the perineum and the vagina for laceration. Next is remove your gloves and wash your hands. The rationale for doing this is to limit the transfer of microorganisms. I will remove my gloves after I clean the instrument, and I will wash my hands after. The last is document the procedure. To to provide accurate data in the care of client. I will document the procedure and record.